Hi, my name is Dr. Rahim Karmali. Welcome to Lowry Endodontics. Today I want to share with you a case that I recently completed which really highlights some of the technological advances in endodontics and how to use it to its full maximum potential. I hope you can learn something from this case. So this patient presented to me in pain isolated to number 28, and testing verified 28 was the source. Radiographically, at least two-dimensionally, you can make out a hint of a potential lucency around the apex of this tooth, meaning a potential abscess. There are three things that concern me about this case. The first is it looks like the root canal treatment has been well done. The anatomy is complex. There's a deep apical split here, which was very well managed. And when I see a well-done root canal treatment failing, I'm concerned as to whether I can fix it or improve it at all. The second thing that concerns me is this lucent area in the chamber. And oftentimes when I see this, especially with the new crown on there, it makes me wonder if there's a retained cotton pellet in the chamber after the restorative was done. The third thing that concerns me is that this part of the root has been overshaped, which weakens the tooth and makes it more likely to snap off in this area, a cervical snap off. Let's see what the 3D scan looks like. High-resolution CBCTs, or 3D scans, has really revolutionized endodontics. We're now able to take a tooth apart visually, radiographically, in 3 dimensions to determine exactly what's going on and figure out the best way to fix it. If we take this tooth and we take horizontal slices, axial slices, moving from the tip of the root down towards, the top of the tooth down towards the tip of the root, when we enter the chamber, we can see this void. And this void is where I'm assuming that there's a retained cotton pellet. As we move down and we can see the root canal fill, it looks very well centered, which is good, and then you see the split. And that split goes all the way to the tip of the root, and then you can see the lucency around the root where that infection is. But if we look carefully, we can see that the root doesn't just split into 2, it actually splits into 3. And this third split has been largely untreated. This is the sagittal view on the CBCT. You can see the deep split which was managed, but here's the third branch which wasn't. So the CT really gives us insight as to why this case isn't working and how we can better address it in the retreatment. This is the tooth prior to access. This is isolated. It's an all-ceramic crown, so we're going to go through it very carefully with a round diamond burr with lots of water. We're going to try to preserve this crown, and we don't want it to fracture. As soon as we access through the crown, we hit a layer of cavit, a temporary material, and then we see the retained cotton pellet. And so the restorative endo transition probably could have been managed a little bit better. So we removed the cotton pellet and we removed the root canal filling material, the gutta percha, from the 2 branches at the tip of the root. The dental operating microscope is another huge advantage in endodontics. It allows us to see things under high magnification and illumination, which without any other way you wouldn't be able to visualize. This is a little bit of the root canal filling material that's stuck in that untreated branch. If we're looking at it radiographically, we're looking down through the top of this tooth to about this level. And we've got great visibility to see where that untreated branch is. So we used a Muntz burr to gently taper away part of that root so it gives me good access into that lingual branch. So here's the buccal branch of the split, here's the mesial branch of the split, and here's the untreated lingual branch. This is what the Muntz Discovery burr looks like. It's a very long shank that's very tiny at the tip, and it comes in different sizes, all the way from a 1/4 round on up. This was a number 1 round, and we can use that with great visibility under the scope to shave away a little bit of that dentin so we can expose that third split. We obturated this case with cones using warm vertical compaction. And because this tooth is a little bit structurally compromised, a fiber post was placed. After the fiber post was placed, the access was closed up with a bonded composite. And with a little bit of luck, you can make these accesses disappear in a lot of these cases. This crown looks brand new. The patient was thrilled. This is the post-op radiograph. Here's the fiber post we placed in the root to prevent this weakened area from breaking, from cervical snap-off. Two-dimensionally, the root canal fill looks pretty good, but we don't really have a sense of where that third branch is. So we acquired a post-op CT to make sure that we've got the anatomy the way we thought we did clinically. So this is a pre-op and a post-op comparative CT. On the pre-op, you can see the two main branches, but the third branch, which was left untreated, you can see a little hint of it here. On the post-op scan, you can see that we got a good dense fill on all three branches. So I'm optimistic about this case. He did great. He's asymptomatic. We're going to be seeing him in 6 months for a follow-up, and hopefully I can show you some osseous regeneration at the apex. So I hope you enjoyed that case. But I thought that case really highlights how having and knowing how to use a high-resolution CBCT, a 3D scan, in conjunction with a dental operating microscope, can make these real complex cases very doable. Thank you so much for watching.